Good afternoon and good evening to everyone. Welcome back to another edition of our Advanced Wound Strategies and Limb Care in Lower Limb Care webinar series that we've been doing over the past number of months with Perfuse MedTech Gecko and the Canadian Home Care Association. We're delighted to have you on again. Today's presentation on improving venous leg ulcer healing is one that we initially were looking to have back in February, and we're just rescheduling to today. So we're happy that you could be on with us. Um, I just want to do a couple little housekeeping items before I introduce today's guest speaker. First off, let's get you clicking on that chat button in your Zoom toolbar. I see there's a lot of people who've already started clicking on it. Once you click on that chat button, let us know where you're tuning in from, and maybe let us know what your role is with wound care, maybe where you work or what your role is. It'll be great to see where we can connect with colleagues from across the country and even abroad. As I mentioned, today's a part of a larger series. So if we are recording today's session, if you want to watch any of the past recordings we had or today's later on, you're welcome to do so. We're going to put those up on demand on our nswoc.ca website after the fact, so you can watch them. We're also going to be providing certificates of attendance today to everyone who is in attendance. And we're also going to be doing a Q&A session at the end of today's presentation. So if you have any questions, do please ask them. But instead of using the chat button, we'll ask that you use the Q&A button in your Zoom toolbar so we can collect as many as we can, organize them, and get to as many as possible throughout that Q&A portion. I forgot to introduce myself. My name's Troy. I'm our Chief Operations Officer at Nurses Specialized in Wound, Ostomy, and Continence Canada, and I'm glad to see all the people from across the country. Alrighty, without further ado, I'm very pleased to introduce once again one of our guest speakers of this entire webinar series, and for today, Dr. Michael Stacey, who's a vascular surgeon with over 30 years of experience in clinical practice and wound care. Originally from Australia, he came to Canada in 2014 as surgeon-in-chief at Hamilton Health Sciences and professor in the Department of Surgery at McMaster University. He completed his medical training at the University of Western Australia, is a fellow of the Royal Australasian College of Surgeons, and holds a Doctor of Surgery degree from research conducted at St. Thomas's Hospital in London, the UK. Dr. Stacey previously served as Chief Medical Executive and Executive Vice President Academic at Hamilton Health Sciences, and he continues his clinical work in vascular surgery and consults in clinical practice, research, and physician leadership. He's led and contributed to major advancements in wound care globally, including serving as the first president of the Australian Wound Management Association and founding chair at the World Union of Wound Healing Societies. His work includes establishing multidisciplinary diabetic foot ulcer and venous leg ulcer clinics in both Australia and here in Canada as well. Welcome back to our webinar series, Dr. Stacey, and I'll pass over the slides to you.
Great. Thanks very much, Troy, and thanks everyone for joining today. And those of you who sort of signed up to hear this about a month ago, my apologies. I got caught in the operating room at that time, actually dealing with a patient with a problem with wound on their leg, doing a bypass procedure, which was a bit more complicated and ran over. That's why we had to postpone that one. Fortunately, the patient's doing well. So today I'm going to be talking about improving venous leg ulcer healing and going beyond compression. So it's really focusing on the other options that we have today beyond just having compression as a choice. So just quickly putting up conflicts of interest. So I do have some active consultancies with different companies, including Perfuse MedTech. Also a member of Woundpedia board, and I've had previous consultancies with different companies. So today, our focus is going to be on understanding the cause of venous leg ulcers as being an impaired calf muscle pump function. I'll just quickly focus on how compression has been used to treat venous leg ulcers and to learn how else calf muscle pump function can be improved by both exercise but also muscle pump activator. And then look at some studies combining compression with muscle pump activation, and then finally look at some of the cost benefits to the healthcare system. So when you think about venous leg ulcers, the key components in treating them are treating the underlying cause of the venous leg ulcer. managing the wound, and then also having options as to what to do when it's not entering a healing phase. Today, the focus will really be on treating that underlying cause of the venous leg ulcer. And the earliest sort of documented history of how we manage leg ulcers really comes from the writings of Hippocrates, who recognized that leg ulcers were definitely a problem. And in his writings, he indicated that it wasn't expedient to stand, nor is it proper to sit. It's better to rest quietly, particularly, which is a particularly expedient way to help to improve the venous leg ulcers. He also recognized that if they're foul, in other words, smelling and what we would term infected, that they're difficult to heal until they're cleaned. And he did at that time advocate wrapping the legs with bandages to manage the swelling and to promote healing. So when we think about venous leg ulcers, Hippocrates may not have fully understood everything that we understand today, but in principle, what he was doing by his recommendations was treating the impaired calf muscle pump function. And that's really the underlying thing that causes venous leg ulcers. That impaired calf muscle pump function can be caused by problems in the deep veins, problems in the superficial veins, sometimes limited ankle movement and limited calf muscle pump function. And that overall produces a higher pressure in the superficial veins in particular when you're ambulating. And I'll just quickly go through how that actually occurs. And if you think of this schematic diaphragm of the calf, with the deep veins being the main veins that take blood out of the leg, and the superficial veins, you'll see there, they drain into the deep veins, which are embedded within the muscles. So that shape there is really the calf muscle that surrounds the deep veins. And when you contract the calf muscle, it squeezes the deep veins, which pushes the blood out of the leg. And then when the muscle relaxes, the valves, which are bivalve, their leaflets join and they stop the blood from refluxing back down into the deep veins lower in the leg. That then allows the pressure to drop. So the pressure goes from about 110 centimeters of water down to about 40 centimeters of water. And that then enables the higher pressure in the superficial veins to drain into the deeper veins, causing that superficial venous pressure to drop. So that's really the way in which the blood is returned out of the leg, and it's that lower pressure that enables that to happen. The problem that you have, particularly when the veins are not functioning, and particularly if the valves are not working, after the muscle is contracted, it still squeezes the blood out of the leg. But when it relaxes, because the valves don't meet, the blood refluxes back down and the pressure doesn't drop. And when the pressure doesn't drop, less blood can flow from the surface to the deep because you don't have that pressure gradient. And what ends up happening is that the blood pressure remains high in the superficial veins. And that's what's referred to as ambulatory venous hypertension. So it's a high level of pressure that is there when you're walking, and it's really that not that it's higher than normal, it's just that it doesn't drop to the normal levels. And this is a schematic diagram just showing you the venous pressure in standing, when walking, and then when stopping and standing again. So whether you've got normal deep veins, varicose veins, or deep venous problems, your pressure when you're standing is essentially the same. But the key is when you're walking and using your calf muscle, you're pumping the blood out, you're reducing the pressure, and so you get that to drop down. If your veins are not functioning normally, or if your calf muscle's not functioning normally, the pressure doesn't drop. And that's what's referred to as ambulatory venous hypertension. And it's that persistent elevated blood pressure or venous pressure that actually leads to a lot of the problems that result in venous ulceration. So if we think about compression therapy, this really has been the mainstay of treatment for trying to improve ambulatory venous hypertension. And what I'll just touch on briefly, is the physiological impact and also its evidence for it improving venous ulcer healing. As I said, this is not a new concept. Hippocrates had this concept, over 2,000 years ago. Since that time, people have used various types of linen, cloth bandages, and even in the 17th century, Richard Wiseman developed a sort of a lace-up wrap, which was made of soft leather, which, as it turns out, was dog leather at that time. Today, though, our options, in principle, do the same thing. So we have multi-layer bandages, which consist of, protection layer, compression layer, and retention layer. Sometimes those are combined, whether you have 2 or 3-layer compression. There are also debates as to whether they should be elastic or inelastic. They have slightly different properties and actions, but not a lot of evidence that they have different impacts on the healing process. We also have the hook and fastener wraps, or the ones with Velcro just shown up on the top right there, and also we have compression stockings. So there's been a lot of work that's shown that this does improve calf muscle pump function. And a lot of that, doing ambulatory venous blood pressures is somewhat more invasive. And so there have been techniques using various types of plethysmography, and this is just showing you one, which is air plethysmography, where you measure the volume in the leg. You start off with the leg elevated, then you put the leg down, and then you look at the volume, that increase in volume that occurs with the leg being dependent. Then you look at how much is pumped out of the leg with one contraction of the calf muscle. And from that, you create what's called the ejection fraction, so the ability to pump blood out of the leg. And then after repeated exercises, then you look at how quickly that blood refills. And you're looking to see, if the valves are damaged, it refills much more quickly. If the valves are functioning, it's a slower refill. And when we look at the impact of compression therapy, so we know that whether it's elastic or inelastic, it does help to control edema. And what it does is it counteracts gravity, whether you're sitting, standing, or walking, and it just helps to stop that fluid from collecting in the soft tissues. But it also improves the calf muscle pump function, and there have been earlier studies looking at the ambulatory venous pressure and showing that that does improve. So it does drop down to a lower pressure if you've got compression on. And just showing you the top right, this is just looking at the ejection fraction with different types of compression, and just showing you that that does improve with compression. And if it's a graduated compression, it improves somewhat more. And the bottom right diagram is showing you how the use of compression increases venous ulcer healing. This is a study we did probably some 30 years ago now, looking at compression versus no compression and looking at the rate of healing of wounds. And you can see it significantly increases healing. The other way we have of improving ambulatory venous hypertension is with exercise programs. And again, this is mostly looking at supervised exercise programs. We'll just touch a little bit on the physiological impact and also on the evidence of improving venous ulcer healing. And once again, a lot of the work with exercise programs has been done with various types of plethysmography. And as I mentioned before, looking particularly at the ejection fraction, which is the ability to pump blood out of the leg, and then that refilling function, how quickly it refills. And if you look at normal subjects versus those who've had venous leg ulcers, you'll see that the ejection fraction is reduced in people who have had venous leg ulcers, and refilling occurs more rapidly. So you've got 8 mils per second as against 2.8 mils per second in the controls. So that more rapid reflux comes from the valves not functioning and the blood quickly refilling that leg. What we also know from other work, and this is from a study that we did, again some years back, looking at the muscle strength in patients who've had venous ulcers versus normal age-matched controls. And you'll see there are a variety of different ways of measuring strength or endurance. You'll see that with the patients who've had venous ulcers, they have a reduced strength, they've reduced endurance compared to those who have uh, no evidence of venous disease and age-matched controls. And when you look at strength, it's mainly the peak torque compared to body weight, where there is a significant difference. So what happens with exercise? Well, what we do know is that with exercise, if you look at this, we've got the patients with venous ulcers. They have here it was a standardized exercise program of doing the maximal number of tiptoe movements over the top of a telephone book, which you don't really get these days. But this did significantly increase that strength, both in patients with venous ulcers, but also in controlled subjects. But if you notice here, if you look at that improvement in those with venous ulcers, it actually improves to the level of what it is in controls before you give them an exercise program. So it actually brings it to what would be regarded as a fairly normal level of strength. And then if you look at measures of um, calf muscle pump function, and here we're just looking at the ejection fraction, you'll see again ejection fraction improves in both those with previous venous ulcers and in controls. But once again, you look at that improvement in those who have had venous ulcers, you'll see that it actually improves it up to and in fact above the level of those controls before they have an exercise program. So this is just showing us that physiologically, exercise increases strength and increases calf muscle pump function. When we go to look at how much it actually improves healing, there have been a number of studies, not a large number, but sufficient to give us a suggestion that it might improve healing. But a recent meta-analysis was unable to show definitive evidence that supervised exercise programs actually improve venous ulcer healing. But there's still more work to be done in that area, but it's certainly not a definitive evidence that it actually improves healing. Some of the limitations of exercise programs, obviously, the improvement only really occurs when the patient's exercising, because if you remember that graph, when you go back to sitting or standing, the pressure returns to that baseline level. And the other thing is that people's ability to exercise may be limited by other medical problems or by joint problems. So not all patients are able to undergo consistent exercise programs. So come to another way of treating ambulatory venous hypertension. That's the muscle pump activator using a device you'll be aware of, which is the Gecko device. So it's an innovative technology that does provide significant improvement in calf muscle pump function. And I'll touch on its physiological impact and on the evidence of healing as I've done for each of the other methodologies. So for those of you who are not familiar with the Gecko device, this is it sitting on someone's leg. You can see the muscles contracting. So the objective of this is to send a signal every 1 second to the common peroneal nerve. Common peroneal nerve supplies the anterior and lateral compartments of the leg, causing those muscles to contract. It also extends the posterior compartment muscles, so that also helps increase venous blood flow and arterial blood flow in both the anterior, lateral, and posterior compartments. Normally, this is worn for 12 hours a day. That's what's recommended. And it can be worn whether the patient's resting, walking, or standing. And this is just showing you very briefly how to apply it. I won't go into that in any detail today, but it can be adjusted to a level where you get muscle contraction, ideally get a little bit of foot eversion and dorsiflexion. Um, but you can adjust it to a level that the patient finds comfortable, and it can be turned off, when the 12 hours have been done. So what does it do physiologically? Well, again, there's a good body of evidence that this improves flow in both the arteries and the veins in healthy subjects, but also in patients with venous ulcers. And in venous ulcers, as in healthy subjects, that flow volume and flow velocity has been assessed by ultrasound methods. In patients with venous ulcers, that flow in the arteries is evident in the femoral artery and also in the tibial vessels. And studies in the veins have shown improvement in blood flow in the femoral and popliteal veins. And this is essentially improving the calf muscle pump function because it's uh, compressing or contracting the muscles, compressing the veins, and increasing the venous return. As well as increasing the venous return and also the arterial blood flow, it also has an impact on microcirculation. And again, this has been demonstrated using laser Doppler techniques or technology, either just with a single probe or with what's called laser spectral contrast imaging. And this has shown that it does improve the circulation or the microcirculation flow both around the wound and also in the base of the wound. And this is just showing you diagrammatically here. This is laser spectral contrast imaging. On the left is what happens with the normal pulsatile flow of blood in the leg, and on the right is what happens when you have the muscle pump activator attached. So that blood flow increases significantly both in the wound bed but also in the tissues around the wound. And then Keith Harding and his group in Wales did a randomized controlled trial looking at evaluating the impact of using the muscle pump activator on patients with venous ulcers in conjunction with standard compression therapy. I won't go into great detail on this slide, but in essence, the study consisted of two phases. The first is a run-in phase, that is from day 0 to day 28 or 4 weeks, where all of the patients were treated with standard of care compression therapy, and the level of healing in their wounds was monitored throughout this. After that 28-day period, they were then randomized to either to continue with standard of care compression or to continue with standard of care compression plus the muscle pump activator. And that carried on for another 28 days. And then they were followed for a further 3 months to look at what happened to the wounds over time. So this is just showing you that randomization, and then ultimately for that sort of further 4 weeks, that's when the trial finished, but the observation of healing carried on beyond that. I just wanted to show you this slide, which is from Keith's study, just showing you some of the different parameters, just to show you that there's no significant difference between the two groups, whether you're looking at age, the height and weight, BMI, ABPI, wound size, how long the ulcer had been present, the ages. But what is of note is that these are not small ulcers. So if you look at it, the mean size in both groups was approximately 10 square centimeters. And they're also not ulcers that have been there just for a short time. So this is the number of days that they'd been there prior to entering the study. So you can see all of these patients had their wounds present for more than a year, some considerably longer than a year. So when they looked at what happened during that run-in phase, this is really showing you the patients who just had the standard of care compression. So you look at their healing rate. So the bar graph on the left is in the run-in phase, and on the right you'll see the treatment phase. There's no significant change in the rate of healing. This is based on the percentage area reduction per day. So it essentially continued at the same rate when you had standard of care compression. When you added muscle pump activation to the standard of care compression, what you see is that that rate of area reduction increased significantly, essentially doubled. And this is highly statistically significant. And there was another way they looked at it as well. It was looking at wound area advancement, so the millimeters per week of ingrowth of the edge of the wound to the ulcer bed. And this is showing you this is the that had the muscle pump activated plus standard of care compression. And you'll see again that wound margin advancement essentially double. And the graph on the bottom right shows you the run-in period, which is a solid grey line. The dotted grey line is the standard of care group, and their rate of ingrowth continued much the same. And then those that had the muscle pump activator, you'll see significant increase, essentially doubling of the rate of wound ingrowth or wound healing. And not only is there that study from Keith Harding and his group, but there's a Canadian experience. This is a paper that was published last year by Holly Murray and her colleagues, where they looked at a prospective group who received standard of care compression plus the muscle pump activator. And they found that the mean days to healing was approximately 40 days. And they compared this to a retrospective cohort where the mean rate of healing was roughly 77 days. So once again, almost a doubling of the rate of healing. In other words, a faster rate of healing when you added the muscle pump activator to standard of care compression. So when you think about the muscle pump activator, there's a few things to consider that does make it stand out a little bit from the other ways of treating calf muscle pump function. Firstly, one of the things we know that it does provide about 60% of the increased blood return to the heart that occurs with walking. So, and the key thing there is that's happening while this is on and being activated, and that's because that's recommended for 12 hours a day in patients with venous ulcers. So you're getting this continuous improvement in venous return to the heart or improvement in calf muscle pump function for the 12 hours that the patient has this device on. Compression basically improves calf muscle pump function when you're walking, but once you stop walking, that muscle contraction is not happening, and so you're not getting that improvement in calf muscle pump function. You are getting control of edema, though, because the compression helps to reduce the swelling. Exercise programs also, they basically work for when you're walking, but when you stop walking, your pressure returns to that baseline. And then when you think of the muscle pump activator, not only is it giving you this continued increase in calf muscle, improvement in calf muscle pump function, there's good evidence that it also helps to reduce edema. So what all of this is really telling us is that, if we think back, compression has been around since Hippocrates' time. It's still a go-to basic way of treating venous ulcers, but it's only a partial solution, for those reasons, and that while it helps to control edema, its improvement in calf muscle pump function only occurs when you're actually walking. And so ideally what we would do is to combine compression with muscle pump activation, which is exactly what Keith Harding and Holly Murray did in their studies, where they were able to demonstrate that this actually improved healing rate, essentially increased the healing rate by almost double when you added this to compression. So when we think of the concept of going beyond compression, we do now have a really good option in looking at the muscle pump activation device. And supervised exercise programs, also there is evidence that it can help, but again, its help is primarily when you're exercising. But I think what we're seeing is that there's very, very good evidence, and we combine compression with muscle pump activation. We're really moving to a new level of understanding of what we can do beyond what we've been able to do with compression alone. And so what's happened with that, in the last few years is that has really started to find its place in, effectively mainstream treatment of venous leg ulcers and to try and incorporate not only this but some other elements of how we treat venous leg ulcers. We got a group together in 2024 to look at what is a good Canadian consensus on the management of venous leg ulcers. So it's a multidisciplinary panel, and it was really trying to look at the principles of treating the underlying cause of ulcers, the principles of wound management, actions if the ulcer's not entering the healing phase, and also how to prevent recurrence. So it was really looking at all elements, but part of what was incorporated in that was using the muscle pump activation device. And I'll just highlight for you a few areas where the muscle pump activation device really found its place in that consensus statement. So to begin with, if patients are not able to tolerate optimal compression, this consensus statement indicated that using the muscle pump activation should be added to those patients, and particularly if they're not able to tolerate, any compression, you might just use a very simple stockinette or a very simple bandage. So basically adding this, if people can't tolerate optimal compression, is really very much the standard of treatment. And I think ultimately we will probably progress to saying we should really add this in most patients who have a venous ulcer, in addition to standard of care compression. Then the other place it finds itself is, so if the wounds are not progressing normally, not entering that healing phase, and this can be defined by either no size reduction in 2 to 4 weeks or less than 30% reduction in 4 weeks. So what do you do? Well, firstly, you make sure you've got your diagnosis right. You make sure that, if you need to take a biopsy or do other tests, you do them because there may be other reasons why that wound's not healing. And also, you also look to see that the protocol that you recommended is actually being implemented and adhered to. You make sure there's no infection present. And then if you've established that all of those things are optimal, then you reassess the compression system, make sure that it's the optimal one. We review their exercise program. If they don't have the muscle pump activation device, and then absolutely at this point, you should be getting it in. As I said, ultimately, we may look at recommending this from the outset in most patients, just from the data that we've seen in Keith Harding's and Holly Murray's papers. And then the other thing is to consider superficial venous ablation, which is another treatment that can be utilized to help improve calf muscle pump function. And then the thing that happens, and as you'll see from Keith Harding's and Holly Murray's papers, is that the combination of compression plus muscle pump activator results in a faster healing time and results in lower cost to the system. And I'll touch on that in a moment. And I'll just touch on, how we can use this in practice. I'll just provide one patient example just to see, where we can use this. So this is one patient, an 89-year-old female. She's had this leg ulcers on both the medial and lateral sides of her legs for over 12 months. And they've been increasing in size in the past 6 months. She also has significant pain. She has other comorbidities, diabetes, hypertension. She had the superficial veins in the right leg, which is where this ulcer is, treated 6 months previously. And they'd been attempting to use some level of compression, but not optimal compression on her leg. Her ankle brachial indices and toe pressures were normal. And so what happened with this patient? So we got her into a dressing that provides some antimicrobial and anti-biofilm activity and a standard 2-layer compression wrap. And with that, you'll see the key points there. So the lighter colored bar is the medial ulcer, the darker one is the lateral ulcer. You see the lateral ulcer started to improve once we got her into good compression. The medial one increased a little bit and then started to improve. And we sometimes see that when we get compression applied. But the key thing then, if you look at that, once they both started to improve, the rate at which they're improving didn't really fit that sort of optimal rate of greater than 30% over 4 weeks. So you see, we ultimately introduced the muscle pump activation device for 4 weeks. And you'll see that the graphs took a downward turn, so improved healing. Again, still didn't quite get to that level that we're looking at. And so we introduced it again. And once again, you'll see the healing rate improve significantly. And again, this was just for a 4 week period. And then ultimately, you'll see that the wounds went on to heal. The medial one at about 14 months, the lateral one at about 10 months. But if you look at this graph, if they'd continued on that trajectory where they were just with compression, this patient would have still needed compression bandaging on that leg for at least an additional 6 months. And really, we were able to speed up that healing when we added in the compression therapy. And so we see that both ulcers did improve more significantly, more quickly rather. The medial one healed 6 months quicker than it would have on that original trajectory. The lateral one, 2 months faster. And the benefits with this are a better quality of life for the patient. The other thing I didn't touch on was the pain level, and you'll see at the bottom, this is their pain score out of 10. It's running at about a 7. It did reduce when we first administered the muscle pump activator. When we stopped it, it went up again a little bit, sort of went down from 7 to 3, then up to 5 again. When we added it in again, it reduced, and then ultimately the pain disappeared once all of the wounds had been healed. But by healing the wound, you reduce the risk of complications. You also reduce the cost of treatment. And what I'll touch on, the final thing, is really the cost effectiveness of adding this into your treatment regimen for patients with venous leg ulcers. And to look at this, we had a group together of myself, Amanda Loney, Graham Cork, who's basically a statistician, a health economist, and also Connie Harris. And many of you will be familiar with Amanda and Connie. So the goal was to look at, so what is the cost of treating a leg ulcer in the Canadian healthcare system? And we used the healing rates that came from that RCT in the UK. And Keith Harding and his group had looked at, what were the cost benefits in the Canadian sector, in the sector in the UK. Well, we were trying to look at, so how does that sort of pan out in Canada? So we looked at, the costs of nursing time, and across Canada, the costs are a little bit different depending on the level of nurse, whether they're an RPN, an RN, or an NSWOCC. And different amounts of time are used for different nurses. More commonly, it's the RPN doing most of the treatment, with NSWOCCs or RNs, being there as less frequent attendances. We also factored in that, their active time of seeing patients roughly equated to 42 weeks per year. This is allowing time for leave, administrative time, and education time. And then we looked at the dressing costs. We looked at, and once again, this is so variable, but, with our sort of small group, we figured that these were some of the costs that would be reasonable given the different types of materials that are used. And then we're able to look at the overall cost, for a visit. And this was assuming the patient attended a clinic, not the nurse attending their home. And these are for patients just with venous ulcers, so not patients, with the more complicated mixed venous arterial type wounds. And again, we factored in that they would, on average, be having a dressing every 2.5 days. Some would have it almost daily to begin with. Others would go to, probably 2 or 3 times a week ultimately. So when we looked at this and we applied the healing data from Keith Harding's study for when you used either standard of care compression alone or standard of care plus muscle pump activation device, So the healing improved, or the average time to healing, you'll see the treatment there, 234 days for standard of care compression, 178 when you added muscle pump activation device. These were the costs of treatment, and with the muscle pump activation device, this was the using the muscle pump activator for 4 weeks. So that's added into that cost as well as the nursing time. But essentially, what it resulted in is faster healing, almost 2 months, and almost $1,000 in savings per patient. So, in other words, even with factoring in the muscle pump activation device, you've saved at least $1,000. Keith Harding's study on costs in the UK provided a little bit of slightly higher, about 12 or 1,300 Canadian dollars per patient. Some of their cost factors were a little bit higher as well. And then there's some additional work, not really been published to date, but looking at patients who've had those longer standing ulcers. So those who've had ulcers for greater than 12 months. So here the patients are treated with standard of care compression plus continuous muscle pump activator until the wounds have healed. And there they found that on average they could be closed in approximately 60 days, as compared to carrying on with the wounds really just not responding, not healing, as they had done for more than a year previously. So there you'll see the cost when you add in the muscle pump activation device, that you've got a savings of nearly $10,000 per patient, and you save them roughly 10 months of a wound. So very significant improvement for the patient and also for the healthcare system. And if we look at this, think about those two groups and extrapolate those numbers across Ontario and also across Canada. And we've used sort of published data on the prevalence of venous leg ulcers, so mean value being about 0.32% of the population. So the number of patients with venous ulcers there. The cost savings, if we treat them just all comers, you'll see that cost savings in Ontario alone, about $50 million, in Canada, 136. But then if we think about using it continuously in those who've had wounds for greater than 12 months, then there is an additional cost savings of more than 100 million in Ontario and 275 million across Canada. So if you put those together, you'll see that potentially across Canada, you can save more than $400 million per year in adding this to standard of care compression. So the benefits really of going beyond compression, which is something that Hippocrates was doing 2,500 years ago. It's about time we started doing something, use things that actually add to compression. But certainly when we can do something to improve calf muscle pump function continuously over 12 hours, what we find adding that to compression, patients have less days with an open wound, less pain and discomfort, less risk of complications, less personal cost, which haven't been factored into those cost analyses. So, their travel costs, their loss of work costs, and an improved quality of life. And in addition, very significantly, there is an improved cost savings for the healthcare system, both with treating patients with standard venous leg ulcers, but also those with long-term non-healing venous leg ulcers. So just so you're aware that Canadian consensus statement on the management of venous leg ulcers, it is available. You can see that there's a website you can go to, which is an independent website, or you can scan this QR code to go to it. You can download a copy of that for free. This has now been endorsed by NSWOCC, by the Canadian Home Care Association, and recently by the Nurse Practitioners Association of Ontario. So certainly does have the support of much of the groups who actually care for patients with chronic wounds on the legs. So With that, Troy, I'll pause and happy to take some questions.
Awesome. Well, thank you so much for going through that, and again for having you on here. I'll just rem whoops, my camera came off there. I'll remind everybody in the chat here, if you do have any questions, please do put those in the Q&A box. If you can't access your Q&A tool and can only put in the chat, you can try put them in there too. Um, let's see if we got one here. So. One person was asking about, can you clarify if a muscle pump activator includes the use of a sequential compression device or a SCD?
Yes, and the muscle pump activator is very different to sequential compression. So the SCD or sequential compression devices are basically pneumatic devices that you put on the leg that will sequentially compress the leg. Um, their use is primarily in patients, who are sitting or lying. They're commonly, or not commonly, but they are used at times for patients, for DVT prevention when they're in hospital in bed after procedures and they can't have um, uh, pharmaceutical prophylaxis for DVT. But they're not a practical solution for patients who are ambulatory. It's a little bit like, walking. Walking helps improve calf muscle pump function when you're walking. SCD can help to do it when you're not walking, but you can only really have it on for a period of time. Whereas the difference here with this muscle pump activator device is that it's functioning for the whole time that it's on. And so you're getting that improvement in calf muscle pump function for that whole 12 hours when it's functional. So different technology, essentially.
Thank you for touching on that. And we had a question here. I know we have Jeff Fournier in the background as well, who can help answer some questions about Gecko and ordering, recommending. But if you can just clarify as well whether Gecko can be recommended or prescribed by family physicians, and more specifically, does it need to be?
I can comment on that, and maybe Jeff can add to it if you like. I
Mhm.
mean, it doesn't need to be prescribed by a physician or a family physician. Indeed, I mean, nurses can access that or recommend it. I think its availability is a little bit patchy across the country, but it is, they're working on making that more available. But Jeff, you may want to comment on that.
Yeah, certainly the device is very safe. There are no contraindications. In fact, we have a sister product that runs at lower power that's used by virtually every sports team in North America that's elite level, meaning professional, NCAA or Olympic. And it is available in Ontario, for example, it's available in special authorization. We're currently in the process of going through um, getting it on the formulary. In fact, it's just started the review today. So hopefully at the end of April, it will be available a little more broadly. There's a question on insurance. Workplace Safety and Insurance Board has expressed willingness to support the device for injured and ill people. And that's currently in the process. The implementation plan that we proposed is currently in the process of being reviewed by them. So hopefully that answers the question.
Thank you for touching on that. Going back over here, you mentioned there's no contraindications, but let's talk about different use cases. Someone was asking about using it in combination with negative pressure wound therapy. Is that okay?
Yeah, so I mean, I'm happy to touch on that. So the short answer is yes. I mean, there's no reason to not use it when you've got negative pressure therapy. Negative pressure therapy basically, is providing that negative pressure over the wound bed, and it does um, things to help the granulation tissue to help the wound healing. Muscle pump activation can still be used with that because you're stimulating the muscles, you're increasing the microcirculation. And if you need negative pressure wound therapy, then the two together, potentially can help to improve healing, beyond what you would get with just one. But maybe Jeff, you want to comment?
Yeah, the only challenge is going to be the cost side, right? Because uh, we don't have any data that suggests that the two working together is better, although I agree with your point. but we don't have anything else to add to that.
Fair enough. And someone was just asking about the clarification why we only apply it for 12 hours rather than a full 24 hours.
Uh,
Yeah, I can speak to that, and maybe Jeff would like to too. I mean, the so there's probably no reason to not use it for a longer period, but in patients with venous leg ulcers, essentially the times when they've got this impaired calf muscle pump function is when their legs are dependent. So basically, when you're lying in bed, or you've got your legs elevated, your venous pressure will reduce because you don't have that gravitational impact. And I think that the rationale, for the study that Keith Harding's group did was to use it for 12 hours, which is largely, the time when patients will be up and mobile. There's no reason to not use it for longer. It doesn't not, deleterious to do that. Um, but it may not be necessary when you're actually lying in bed. However, potentially you could. I mean, all it does potentially is just add a little bit to the cost, I would think. But maybe Jeff, you want to comment on that?
yeah, we did a dosimetry study that 6 hours versus 12 hours, and 12 hours ended up being better. The challenge that we find with these patients is that the one side effect with the device is skin irritation. And while we don't really have a solid answer on going 24 hours, if we can avoid skin irritation, 24 hours would probably be better. But that's the rationale as to why it's recommended at 12.
And maybe, Troy, I can just add an extra piece to that too. Like we've also been looking that, there's ongoing work at looking at using this in patients with, problem diabetic foot ulcers and patients with problems with arterial wounds, for which you don't have too many other options of treatment. And there, it is a question as to, what is the best duration to use it, and for some of them, because the pain's worse at night, it may be better to use it at night than through the day. So I think we've still got a lot more to learn about the duration that we apply this for the different types of wounds, but there's certainly very good evidence that whether it's diabetic foot ulcers, arterial ulcers, or venous leg ulcers, the microcirculation is improved in all of those. And improving microcirculation improves healing. So, I think there's reasonably good rationale for why to do 12 hours, during daylight hours for patients with venous leg ulcers. But we're still evolving what's the best duration for the other types of wounds. But Jeff, did you want to comment on that
Yeah, no,
further?
I think that's fair because it's uncharted territory. So we're doing the best with the knowledge we have today. 10 years from now, it might be a different story. But that's the nature of technology. As you learn more, you adjust based on your learnings.
And I think, Troy, with the other types of wounds, that we are getting more and more data showing benefit both in reducing pain, but also in improving healing in, things like arterial and diabetic foot ulcers. We don't have quite the level of evidence that we have with venous ulcers with the RCTs and those cohort studies. But over time, as Jeff has said, that data will develop and will improve, and we'll have stronger data for using it in those groups.
And would that apply as well? I see Dr. Pearsonowski has also asked about has there been any work done or studies with patients with lymphedema and gecko?
Yeah, so probably not. Maybe Jeff can comment on this. Not to my knowledge, any large studies on lymphedema. There has definitely been some work looking at post-operative edema in people with renal transplants, where it is shown to reduce the swelling and the edema. But Jeff, you may want to comment more on that.
Yeah, it's certainly like preoperative edema, postoperative edema. We have a lot of data on that. But lymphedema, we have a few case studies, and our sense is that we empty the venous system, but we're not emptying the lymph system. And I think that there's more work to be done. But the challenge in lymphedema is that it's a chronic condition, and we don't believe that we have the cost effectiveness to go along with that.
Fair enough. We had a question here from someone working in Nunavut who is asking about maybe just your suggestions for working with patients who are maybe a little bit more difficult to wanting to follow through with wearing their compression stockings for venous leg ulcers. Maybe what's some recommendations you can give for people who are dealing with those who maybe don't want to agree to that sort of care plan or refusing compression with venous leg ulcers?
Yeah, no, that's a really good question because really, those of us who treat a lot of patients with venous leg ulcers, there is a significant, cohort um, who really don't like wearing compression, can't tolerate compression. Um, someone will put the compression on, they'll take them off. What we do know, so two things that I'd recommend there. Definitely, those are a group of patients where, this muscle pump activation device can do something. Whereas if they have no compression, they're effectively not getting anything. The other thing I've also personally used in those groups of patients is to use those hook and fastener or the Velcro type wraps on the leg, which the patient can take on, put on themselves, can take off when they want to take them off. With those, when they've got their legs up, particularly in bed at night, it's probably okay to take them off because you don't need that. But if they're using something like that and you add this device, then you're probably getting pretty good improvement in calf muscle pump function. But yes, there's some patients who simply won't continue to wear compression, whether it's stockings or wraps of some form. But I think something that they can apply and take off themselves, like the Velcro type wraps, I think is a good option. And of course, they can apply the MPA or the Gecko device themselves as well. So they have a little bit more control, over things then. Jeff,
And
any
one
other
thing.
comments?
Nothing to add, no.
I was gonna quickly note that for those who didn't have a chance to watch it, maybe you can still go and access our Compression Unraveled webinar. That was a part of this same Advanced Wound Strategies and Lower Limb Care series. We did that one back in November, but on the same website where you can register for webinars, it's also where we post our past ones. And what we'll do is when we send you the certificate of attendance and the recording after today's webinar, we'll probably actually get it by Wednesday. We'll have it in your inboxes. You can actually go take a look at that one. I believe that was with Dr. Evans and Dr. Sibbald, and they covered quite a bit too. So maybe some other strategies for managing
Mhm.
compression as well, and would be a good thing to go and check out.
Good
I
stuff.
know we're coming into the last couple minutes here. I know we got lots of questions about ordering, about pricing, all this kind of stuff too. Jeff, what we can maybe do as well is for those who want to get a little bit more information for their area, we can put in that email, same thing, how to get in touch with Perfuse MedTech or what the best route is to learning a little bit more on that standpoint. Did you want to comment though on anything related to ordering or accessing the information, or do I point them to the website perhaps?
Yeah, I think it's like the product is available to anyone. It doesn't need a prescription. So it's through Trudell Healthcare Solutions right now. And we are working with other companies to make it available with bigger distributors. So that should happen in the next few weeks. But the bottom line is that it's available in BC on the formulary. We're in process in Alberta, Saskatchewan, Manitoba. It's available in Nova Scotia and New Brunswick. Ontario, I mentioned earlier, and Quebec, there's a lot of interest. So it should be available, across the country, hopefully by the end of the year.
Thank you. I don't have any other questions in the chat, and that's perfect right at the hour here. So, just a friendly reminder to everyone, if you haven't already, do take a quick look. If you're going to be in the Vancouver area, if you're already registered for the Congress, or if you haven't registered and you're still considering it, Perfuse MedTech and Gecko will be having a presentation during the lunchtime session on, I believe it was, let me just double check here so I don't get it wrong. On Saturday at lunchtime, there will be a sponsored presentation at the WCET NSWOCC Joint Congress in Vancouver. You'll also be there, of course, with an exhibit an exhibit table as one of our platinum sponsors. So we do encourage you, if you're going to be there, do come to that session, but also come and ask some questions there. I'm sure there'll be even more updates at that stage as well. So Dr. Stacey will be one of the guest speakers for that one. So we look forward to seeing you in just over a month's time from now. But thank you again, Dr. Stacey, for a fantastic presentation, and we'll see you again on during our webinar series that continues. For all those online, as I said, wait until about the end of the day Wednesday. We'll have the certificates and the recording in your inbox, if not sooner. And we look forward to seeing you on for another webinar. Thanks, everyone.
Thank
Great.
you.
Thanks for joining, everyone. So very, very pleased to be able to deliver this to you with the delay we had last time. So thank you.
Yep. Cheers. Thank you.